Welcome everyone. So today we are talking about ADHD and physical health, and we're thinking specifically around women's health and hormones. So Corina and Penny, we were going to kick this off with thinking around adolescence and assessing girls in clinic and what we need to consider within our clinical assessments when we're kind of working and thinking about ADHD early on. Have either of you have any thoughts around this?
Yeah, I think in all honesty, it's something that when I was working in clinical practice more so, I didn't consider it enough. And I think just, now kind of what we know about some of the research, what we know, I wish it was something that I had considered more, particularly for adolescent females around puberty. So I think there's work coming out now. I think it's a really important issue, but in all honesty, I don't think it was something that I considered enough a few years back.
Yeah, and I would agree with that. And I think the sort of identification of ADHD in young people, children and young people, before the pubescent stage tends to be the boys, the sort of male population. And even when I was working clinically in ADHD, I think that is very much the focus. And when these girls starting to come through, being referred in at puberty, maybe a school change, I agree with you, Corina. I don't think the information is there to identify quickly enough that these girls may be presenting with ADHD. Often it's thought of as other things. Oh, it's just your hormones. It's just this. It's just that. And often the assessments get rejected or delayed because that the information just is not clear enough for these young girls.
I spent quite a long time working in CAMS, and I often saw young women coming in where there was a significant trauma history. Working in London, may have been gang associations, but predominantly what we saw the referral information coming in as was for anxiety or depression. Mm-hmm. And then as we began to do our initial assessment, you're starting to unpick, hold on, there's neurodivergence here as well. But it wasn't until I started kind of working more in pediatrics and we're thinking kind of a bit more from a physiological perspective as well, that considering the hormonal cycle of the young woman in front of you really started to come on board or come into my mind a little bit more. And I can distinctly remember having a cohort of young women who really struggled with their kind of premenstrual period, to the point where, and I know this is anecdotal in the literature, but I would have to amend the medication, how I was prescribing their medication during that period, because they were telling me, like, Jess, my meds don't feel effective. I'm feeling really, really low. And for some young people, it ended up in much more risk, self-harm, suicidal behaviours during that period, or this kind of extreme emotional lability, that it really gets you thinking about where we are in the month and kind of hormonal stresses as well as the external environment as well.
Yeah. And I think that even links into out of adolescence and into just kind of, women in general at reproductive ages. There's a couple of studies that have came out recently. They're kind of small scale. They've got a few hundred participants in each, but it's saying these exact things, Jess, where unfortunately for women who suffer from ADHD, they're actually more likely to experience premenstrual dysphoric disorder. They're more likely to experience depression and anxiety, and couple all these things, being a woman, having likelihood of having these things, and you've also got ADHD and you're trying to manage that. And then, oh wait, during the month, this may change, your symptoms may be more severe during certain stages. I can imagine it's just so complex for individuals, but also for practitioners. And how do we, manage, how do we support women? What do we do? So yeah, I think that's really interesting what you're saying. There was a study done recently by a team Professor Sandra Coy and her team, De Jong and other authors there. Again, I think they only looked at about 9 participants, but they're looking at how do we support women to change the dosage of medication to suit them, because actually some women were just doing it on their own without having support. They were upping their dosage because they felt they needed more stimulant medication at certain times. So that's really interesting, Jess, that you're also, you've had that experience in adolescence as well.
Well, and I was also listening to Sandra Coy's podcast, kind of narrating some of this information as well. And I think, again, thinking about it with my prescribing hat on, I'm normally trying to think about the medications, kind of work backwards to the neurobiology of ADHD and what I'm seeing in symptom presentation in front of me. And she raised a really interesting point around the function of estrogen and how it works as a kind of like an adjunct, an agonist, to dopamine. And so during that week before our period, when our estrogen levels drop, it also brings down our dopamine levels. And that's part of the trigger for this kind of real dip in mood, but also these symptoms that seem to change as well. And I think as this information comes out, because as you say, there's so little research, relatively speaking, on women, that it really gets you thinking, okay, when I'm in clinic, how am I going to think about this? And what is it that I'm seeing in these young women, or what are they telling me in their own words, that means that, okay, we need to think differently about what these symptoms are presenting with.
And just along those lines, I think we're talking very much about the already diagnosed young ladies in puberty, but things like symptom diaries are going to be really important, which aren't usually asked for when you're doing an ADHD assessment. But I think it's particularly important when you are looking at assessing young ladies or young people with in this pubescent period, to really go into depth about what is different now, because these people will already have been symptomatic of potential ADHD. So they will have probably have some identified sort of preceding symptomology of ADHD, but what we will be seeing is that at these particular times their symptomology gets worse. As Jess said, we can see as the estrogen decreases, so does the dopamine. So for getting a really detailed symptom diary of what happens during the menstrual cycle is going to be key to how we're going to treat these young people.
And I know, Penny, your background is as or one of your kind of clinical backgrounds is as a sleep practitioner, sleep specialist, and so you might be more kind of confident with utilizing diaries to track, I guess, when we're doing this clinically, because it's not something that we encounter that often. You generally have like quite a short session, maybe an hour, to get all of this right. Where would we place this in our assessment of young women? Do you think they're likely to adhere to it as well, having ADHD symptoms, or are people using apps to track their cycles now? I'm just curious how we bring this into the assessment clinic, I guess even with smartwatches, that sort of thing as well.
Yeah, and I think diarising symptomology, I mean, I know my daughter has an app to manage her cycle, and I think this is quite commonly done these days. Yeah. So again, I think, encouraging these young people to almost take ownership of their symptoms and come in and be part of that assessment process.
Yeah, it's really, really important, because I guess it's so individual, isn't it? I mean, we know ADHD symptoms are so individualized anyway, that when you add in your own experience of your hormonal fluctuations on top, and how you experience that in the month, how heavy your cycle is, whether it's regular or not as well, it's going to have a huge impact. And we've not even talked about impact of oral contraceptives, why you've utilized that, and those kind of young women and adults who experience polycystic ovary syndrome as well. So there's a lot of factors to take into account. I'm curious if some of this, because it's really nuanced and kind of gathering all of this, and we see a lot in the literature about kind of this hypothesis that women are often under the ADD, historically called, or predominantly inattentive type ADHD category. Do you feel that sometimes in assessments, especially when we're thinking about adolescence, we could be thinking about those hyperactive and impulsive symptoms and how that might come out differently, either based on hormonal fluctuations or how girls differ from boys in the teenage years?
Yeah, I think it's an excellent point, because I think, unfortunately, a lot of the rating scales that are used, even some of the criteria in ICD and DSM, it's based on research that's predominantly conducted on children and predominantly conducted on boys. And I know there's a lot of people out there advocating for need more research for women, but also for adults in general and for adolescents. And I think then when you're looking at the symptoms around hyperactivity and impulsivity, there can be things that are maybe missed in the rating scales and the criteria, but also in our own, I think, biases and what we envision as somebody who has ADHD, who's hyperactive. We typically envision kind of younger children, maybe boys, running around a classroom, having difficulty sitting still. But it's exactly like you're saying, Jess, it can present differently. It can present that way in women and adolescents, but sometimes it can present very differently. It can be more subtle, fidgeting type behaviours, tapping a foot, tapping of fingers, always having something in your hand. And I think, especially when there's a lot of, telepsychiatry appointments, etc. as well, I think it's important to try and look at these behaviours and consider that full range of behaviours when we're looking at hyperactivity. It might be not so obvious. It could be more subtle type behaviours that I think, we need to be looking out for when we're conducting assessments and considering that hyperactive component, definitely.
But it is interesting. So my background reading I've done prior to our discussions today, there is some research out there to say that actually the hyperactivity and impulsivity is not particularly triggered by the change in the imbalance in hormones. So I think it's interesting that should we be looking more at at that sort of more, it seems, the inattentive and the executive functioning side of things, which are in the sort of frontal area of the brain, rather than sort of focusing on that hyperactivity and impulsivity.
I do wonder, though, if sometimes we can misdirect with our questioning during assessments, especially with adolescent girls, because sometimes there are questions which are just a little bit uncomfortable to be asking about. And we're thinking about girls who are now at a sexually reproductive age, and impulsivity may come as sexual impulsivity as well. Yes. And therefore, we know that teenage pregnancy rates are higher. I was reading a Swedish study by London and colleagues from 2003, and they were, how Sweden have that kind of massive consensus data, and they were looking at kind of teenage pregnancies, and although they were generally low, women and girls with ADHD were 6 times more likely to be pregnant during their teen years. And I know working in London, we did our best to kind of work closely with the sexual health clinics, because even if it's not pregnancy, it could be sexually transmitted diseases that we need to think about as well. And again, we're kind of steering back around. Obviously, it's around the choice of the young woman, but the role of working interagency, working with kind of people as mental health clinicians. You might not ordinarily think to kind of set up a working relationship with the sexual health clinic, but it's one of those really key relationships in order to keep young women kind of healthy and safe during their teenage years as well.
Yeah, I think it can be even more complex. And so as much as I've got a British accent, I'm based in the US. And I think even here, unfortunately, kind of the way it works a lot of the time is that it would be difficult to almost work interagency. The kind of structures and etc. here is quite different. So that's why I think what we're discussing around ensuring these aspects are in your assessment, because you might be the only clinician meeting with this person to make that assessment, and you may not have the resources, and this will be the same in other places as well. You may not have the access to other agencies, which would be so beneficial. So I think having these thoughts in mind, considering hormones, adolescence, like we're talking about diaries here, having all this information and considering that, I think can be so helpful when you're then trying to tailor your treatment, your approach, your recommendations, whatever it is you're providing to women and to girls in particular. And it also links to something that I've been looking at around women, and I wonder what your thoughts are here on even just psychoeducation around hormones, menstrual cycles. You two are much more experienced at me at knowing about hormones. My background as a psychologist, I'm not a prescriber. I don't have the experience that you guys have, but even myself, I'm like, I could do with some psychoeducation and some of these topics. And I've seen some good treatment programs that are coming out again by Sandra Coy and her team, where they've started developing like ADHD specific treatment programs for women, encompassing things like diaries, things like psychoeducation. So I wonder what your thoughts are on that.
And I think that's key, Corina. I think education, again, is something that is sort of the poor relation. We talk about diagnosing and medicating, but where you've got the juxtaposition of these hormones directly relating to the ADHD symptomology, psychoeducation is so key to management of ADHD in women. And again, my background as a midwife and health visitor, I've sort of lived my life amongst these women and young people. And yeah, I think the sort of times that the risky behaviours might happen. Again, it's that diary. When do you feel that you're more at risk of doing things? Is there a pattern that happens here? And helping these young people understand, before the unwanted pregnancies or something like that happens. So it's looking at, where will this education happen? Do we need to try and support people or services developing the sort of special groups for these young girls to attend, to actually sort of give them that additional support, because this isn't just for puberty or time of puberty. This is through their life expanse, isn't it? And I think it'd be really helpful to sort of develop some sort of educational program for these young women right from the beginning.
I also think there's almost sometimes an assumption, like in Corina, you were saying, oh, Jess and Penny, you might know more. Obviously, Penny's a midwife, definitely knows more. I'm a child and adolescent mental health nurse, an advanced nurse practitioner. I'm a non-medical prescriber, but I'm reading the literature, and I didn't know that for contraceptives for women with ADHD, you shouldn't take a break, because the destabilizing of the hormone, and by taking a week off with an oral contraceptive, you're actually better with a slow release. So I think even in a clinical perspective, when you're in your lane, I prescribe the medications I prescribe. I'm wondering where the education needs to start, because you do sex education in schools. I don't know how many parents would know this information as well. And even as grown women, like, were we given the information to kind of have agency over our own bodies? And it's a lot of this you come to later, when you're starting to kind of be a little bit more self-aware, and you're thinking, okay, how do I take ownership over myself? I think the generations coming through are much better at that, but it's how do we provide access to the right information in a digestible form, so for them, they can then make the decision with their GP or their sexual health nurse or their ADHD practitioners to go, okay, I think this combination of treatment, whether it's pharmacological or non-pharmacological, would suit me and my body best.
Yeah, I think that is really, I agree with you, Jess. Even coming from that background, when I was health visiting, which is sort of my career before coming into this role, I didn't even recognize it. I was going to see many mothers with postnatal depression, with who were really, really very unwell, and their babies were being affected by this. They may have been under a perimental health team, But I'm not even aware that the perimental the health team actually brought in any considerations around what else might be affecting this really quite devastating postnatal depression. So having done the research for today and working for the past few years in with Qbtech, I think we're recognizing that this is a huge gap in women's health that needs to be filled.
And Corina, you're quite interested in women at reproductive age, kind of whether or not they're considering to have children or kind of after having children. Is there anything kind of as these girls and adolescents, either that we've seen in clinic or that have been missed? Do you have any thoughts about kind of women in their 20s, 30s, early 40s and how ADHD and hormones might be impacting this cohort of women?
Yeah, I think it links to a lot of what you've both been talking about here, even with the kind of adolescent group around considering your monthly cycle and potentially, you're talking here about some of the work that's coming out around potentially adjusting your medication, etc., when you're experiencing more severe symptoms of that premenstrual period. There's also some really interesting studies coming out that are quite actually disheartening, unfortunately, but there's a couple of big studies. One is based on this Swedish cohort that you were talking about already, Jess, where what they did was they looked at data from 2005 to 2013, women who were diagnosed with ADHD prior to being pregnant. And then what they did was they looked at that postpartum 1 year after they had their first biological child and were looking to see, okay, was anything else going on here? Were they diagnosed with anything else? Because there's a concern around the hormone fluctuations at that period, that postnatal period, that postpartum period, sorry. And what they found was that 17% of women who had ADHD were diagnosed with depression disorders postpartum. 25% of women were diagnosed with anxiety disorders postpartum, compared to roughly 3 to 4% of women who did not have ADHD. So we're seeing here, we know there is a lot of kind of overlap, unfortunately, between ADHD and mental health conditions, but we're seeing, especially in this postpartum period, and as Penny was already saying, women can be really vulnerable, unfortunately, to other mental health conditions. And there's also some research out there saying that women who were not diagnosed as a child, they were potentially missed or unfortunately potentially wrongly diagnosed with something else. What we're seeing is that then after they have children, the complexities of the hormone fluctuations and just the life that changes after you have children, women can really find themselves struggling. And there's some studies here looking at women who, after they've had children or after even their children have been diagnosed, they're then getting more information on what is ADHD, what are the symptoms like, and it's kind of resonating with them, and they're going, okay, actually, maybe this explains some of what I've experienced that potentially was misdiagnosed or just missed in general. And there's some studies, of women coming out saying, I've got this kind of race car brain, talking about these things that we now hear and we know kind of anecdotally they're related to some symptoms here, but coming out saying, it wasn't until I had children, my first child, then I'm trying to manage everything that comes with that now I've been diagnosed as ADHD and trying to accept that a little bit as I'm a little bit older and realizing, these kind of missed opportunities to be diagnosed throughout it. So yeah, there's some work coming out. There's not enough research, I think, as we all know and say. There's definitely not enough research done on women. I think there should be more, but the information that's coming out is alarming, kind of highlighting that, women need more support given these complexities relating to hormone fluctuations, etc.
And I think I had been reading a little bit around this as well, and my understanding is that kind of drop in estrogen after baby is born in the postpartum period can often be a trigger to this kind of depression. Penny, you're nodding. I feel like you know more around this. Yeah.
And it's so obvious when I think is the interesting thing, that once it's like, well, that absolutely makes sense about why is this particular person feeling so awful. And I sort of wonder, and I've again sort of reading around things and listening to things, wondering about sort of how if someone's well scaffolded, say in school, in a nice small school, and then moves into a nice or a relationship where they're scaffolded, but if that scaffolding goes, that's when you're going to see that symptomology. So somebody may appear to be managing really well, able to write lists, have the time to do it, and then something changes. And that's when you see the catastrophic changes in that person who looked, fairly, very contained, able to manage. And that could be a trigger from that massive reduction in estrogen after giving birth. That could just trigger, because that's just so massive, that could trigger those ADHD symptoms to, really come out, and cause what we would outwardly see as ADHD symptomology. But often that's ignored, and people will, or not understood, and people will think, well, that's just depression. But has this been a long-standing scaffolded ADHD symptomology this person's been able to manage, and then massive drop in estrogen, which is massively more than the one in the premenstrual period, and this is the trigger. And I think
am I right in thinking that because estrogen, we're learning now, although we characterize it as a hormone, functions as a neurotransmitter, and so because it has this impact on dopamine, and dopaminergic function impacts serotonergic function, which is what then impacts our mood. So are we saying that as the estrogen dips, the dopamine is kind of pulled down, which then impacts the serotonin production? So we end up with a woman who is low on estrogen, low on dopamine, low in serotonin. And so I am then assuming that in that postpartum period, if they're being diagnosed, that some women are possibly going to be started on SSRIs, but it may be missed that actually this is ADHD, and that dopaminergic part isn't then supported. There must be a really complex time for women after childbirth who are also wrestling with undiagnosed symptoms, and trying to learn how to be a new mother, with even from a stimulus perspective. As we know, ADHD often comes with some sensory elements as well. So if you're already sleep deprived, you must be feeling so overwhelmed. I can't begin to imagine what's then needed in order to kind of get back to baseline or a new normal from there as well.
Yeah. And I think a lot of women just, because postnatal depression is, kind of well known now, I would say more so. I don't think any women would sit and think, I think this is ADHD. I don't. I think they're just thinking so much else is going on. It must be postnatal depression, like you're saying, I'm going to go to the doctor. And I think a lot of the time also as healthcare professionals, it's what you kind of, because of the rates of postnatal depression, it's where the kind of the first line would go for a lot of people, unfortunately. But I don't know if this is true, Penny. I remember my OBGYN, as we call them here in the US, told me that after you have a child, the hormone drop is so severe that you're essentially in a mini menopause for a period of time. Like you can be experiencing the night sweats. It's like a horrific hormone change that kind of replicates, because I know that you've been doing a lot of reading around kind of menopause. Is that true? I've always wondered if he was
absolutely true. It's the same sort of drop. So if you think about that and then think about menopause, that drop is again very severe and then doesn't pick up again. So obviously postnatally it will pick up again, but how long that takes is, it depends on each individual and how it picks up. But again, I wonder whether postnatally, if that cycle returns, then are women just thinking, oh, this is still depression. It's still depression. Once a month, it must be my hormones. And I think that's a really good point, because again, I think a lot of women are now recognizing the ADHD symptomology in perimenopause, because they have that massive dip again. It's like going back to wow, this is how I felt after I had my child, but I actually haven't just had a child. What's going on? And this where they've been having their cycles, there has been some respite from it, or they've managed it in some other way, maybe focused on children. There's been other things that have taken them away from thinking about themselves. And when they have that sudden dip in perimenopause again, it's that shock of, wow, this brain fog's come back. I can't, I'm not sleeping. There's people who've gone, women have gone thinking they've actually got dementia and gone to have MRIs done and scans because they feel that they're overwhelmed with this deterioration in their executive functioning, which they sort of can relate back to when they had their children, but that was postnatal depression. So imagine somebody who's gone through that whole life of their reproductive years, up and down, thinking this was premenstrual syndrome, this was postnatal depression, and then finally thinking it's dementia, but then finally recognizing, my goodness, this has been ADHD all this time.
And I was at the UCAN conference earlier in the year, so the kind of adult ADHD network, and there was a discussion point there, not only from women and clinicians in the audience, but also some of the speakers on stage, saying there's a real rise in people reaching kind of perimenopause and going to their GPs and starting to think about ADHD symptoms. There's a real balance, isn't there? Because finally, maybe you're thinking, okay, I think I'm starting to understand what's happening here. There's a lot more awareness in the media now, but equally, there must be some grieving for time past. And I'm sure there's some of those internalized thoughts of, like, what's wrong with me? Why can't I just shift this? Or why can't I get this right? And so on the one hand, it's really empowering that we've now starting to get more of this information. But Corina, you were saying earlier that even though we've got more research coming through, we're still in small pools, aren't we, at the moment? It's hard to kind of generalize. And have you read anything around perimenopause or menopause, either of you? Kind of anything that you're excited about or kind of builds on this?
Well, I mean, that as you say, Jess, there is more and more coming out around perimenopause. And my feeling is that, yes, it can be, at the moment, a lot of women are being treated with hormone replacement therapy, which often does support it, but you're not going to get a complete treatment or symptomology sort of disappearing. And I think what happens in perimenopause is with HRT, it gets increased, and then you can only increase it so far, and symptomology isn't changing. Maybe women are then put on the SSRIs because they've still got some other symptomology, and there just is not. I mean, Sandra Coy is doing it. She's being an absolute sort of stalwart of moving this forward. And Susan Young as well is doing quite a lot of research at the moment into women and perimenopause. But again, it's ADHD seems to be at the bottom of the thought process pile when you're treating this symptomology. And again, I think history, so obviously these symptoms will have been around. This person doesn't just get ADHD in their perimenopause, they will have had symptomology. So this is where a really detailed clinical history is going to be key to making that final assessment, and hopefully treating these women in the latter part of their life with everything else that the baggage that's come with that through a sort of a late diagnosis. Because we know that there's been a lot of these women have had multiple job changes, relationship breakdowns, possible children who they've had to advocate for because they may have ADHD. So there's a lot of women out there who have, gone through this struggle, and as you said, Jess, finally get this, well, this is what the issue is, and we can help you.
And sorry to interrupt you there, Penny, but what I was wondering is, once you've gone through that length of time, let's say you're reaching kind of your late 40s, early 50s, and you're thinking, hold on, ADHD, that does describe me, these are my people. Is it likely that as like women have learned masking or camouflaging symptoms over the years, all of these strategies that kind of almost reinforce, like, no, I don't need to go to the doctor about this. This isn't for me. I'd be really curious of because I've seen it a lot in adolescents, even early on, which is really interesting that it's almost ingrained in girls and women from quite an early age, particularly when there's some perfectionist traits or some anxiety in the mix. But we also see those high achievers. Maybe they've achieved well academically throughout their career. They've done excellently. But then you get these pockets of burnout and other factors which might give a little inkling that, yes, they're giving 150%, but for what cost? And I'm curious if either of you have any thoughts around kind of camouflage symptoms of neurodivergence across the lifespan of women.
Yeah, definitely. And I think, again, it's something that is really pivotal to look at in assessments as well, around whatever terms we're using, masking, compensatory strategies, and that can be, I think, harder to pick up in an assessment. I think you really need to be looking out for those things, because if you ask somebody masking symptoms, a lot of people are not going to know that or recognize that or even consider that. I think we're hearing a lot more about it now in social media, etc., which is great. But I think really listening out for those in your assessments and looking out for, especially when someone's coming to you as a kind of older adolescent or, female of reproductive age or at that perimenopausal stage, looking out for these potential symptoms. Because I do think sometimes people will think, well, they can't have ADHD, they've managed this long. They've got a PhD, or, they've successfully raised 3 children and held down a job and ran their household. How can they now have ADHD? I think there's that kind of stigma with it. I don't know if you agree, Penny.
Yeah, I do. And again, I think on that point, a lot of people do think, well, ADHD only happens in children. So if it hasn't been diagnosed as a child, then of course you haven't got it. And because of those hormones again, they can be, we can just blame the hormones. It's the hormones that are causing you to be like this. And it's very easy to accept that. Is that if everybody's telling you that, then eventually you'll go, well, that's what my doctor says, so I'm not going to bother them again, because I've knocked on that door too many times and I've been given the same answer. And so I'm just going to go away and live this life with my hormones that are causing me this problem, which, is a really sad thing to have to accept, isn't it, when there could have been a very different solution for that person.
And people can be given other diagnoses as well. So I know in clinic, going back to mothers, I often saw women who had been diagnosed with like emotionally unstable personality disorder or bipolar disorder. Whereas when you were talking through kind of the symptoms of their children, you were realizing that there was ADHD, autism, or other neurodivergence under the surface as well. So going back to what you said, it's so important to pick out those symptoms correctly, isn't it? Because that just won't go away if you're treating the wrong thing.
Have our rating scales for for our assessments, but they are not in any way directed at sort of individual lifespans of, well, you have children and adult ones, but they're not male and female, so everyone is bunched into the same or to use the same assessment tools. And that's where I think when busy clinics where you're looking at the subjective information, that's where the questions are not often specific enough for that individual.
Yeah. And there's also women in our community as well who biologically at birth may have been born male and have transitioned and we've talked a lot about hormones today. If you've been on hormonal supplements throughout your life in order to transition into the sex that you feel you should have been born as at birth, again, that must add so much to symptomology and how your ADHD symptoms are expressed. And within my clinic, I was specializing in kind of children and young people. And so we had a few young people who were non-binary or kind of beginning to transition or consider hormonal intervention. But that's predominantly prescribed over the age of 18. So, but my understanding is that there's not a wealth of there's not a wealth of research for these women who have been on estrogen hormonal supplements throughout their lifespan and then their presentation of neurodivergence, because we know that there is a prevalence there, and we know that kind of how we're supporting and considering women, and we've talked about the developmental lifespan approach. So again, I'm not sure if either of you, you're both nodding. Do you feel we have enough information, or do you know have any additional information for this community?
Sadly not. I couldn't find any papers for this community whatsoever. And there may be papers out there that I've missed. However, I did like a good search because I was intrigued by this. But again, even the amount of papers on women, I could fit easily on 44 pages, like short summaries. And I have some clinics who are very interested in this currently. I think it's a hot topic, which is great. So I'm always kind of scouring to see what is out there to send them papers and things. Most of it's done in Europe, particularly Sweden, Netherlands. There's some work in the UK. I've seen there's like an expert consensus paper in the UK that came out in 2020, which is great. I think some of the research is saying that's fabulous that these experts are saying we need to be considering women, especially in transition phases. However, I could see a number of people were saying, but how do we do that? The paper's great to advocate for it, but I think a lot of people are going, but how? So yeah, I definitely think that there needs to be more research, especially for particular communities, for women in general. I just don't think there is enough.
And we've not even touched on comorbidity, co-occurring needs. And we've been quite considered to think about ADHD and hormones in women. And we've kind of talked a little bit about postpartum depression and that sort of thing. And whilst this is probably a discussion for another time, we've not even started to think about the complexity of kind of trauma, adverse life events, bipolar disorder, tics and Tourette's, anxiety, depression, psychosis, schizophrenia. There is so many other intricacies that we are very seldom treating ADHD on its own. It's such an important part of the puzzle to get right. And I know in my clinical practice, if we're just diagnosing ADHD, my curiosity has always been, what have we missed? Is there a learning difference or a specific need that would just help improve this person's quality of life? And where research is kind of, it's a growing area and people are doing a wonderful job kind of advocating for women in the research sphere. I'd be really curious around, we're seeing use of social media now, about how kind of women themselves advocate for their symptoms and their needs kind of towards us as clinicians.
And I think we don't need to wait for this research, really, do we? We've identified that the hormones will affect ADHD symptomology. So I think, again, we talked about this right at the beginning, it's educating. We need to educate people, clinicians, health professionals, and actually the general public on, how does this affect you, and how can we manage it for you? Because the medications are all already there, they're all licensed. It's about making that assessment and managing it in the right way.
And I think you're right, Penny, because the treatment doesn't differ whether you're male or female. It's about kind of tailoring your kind of approach, isn't it, post-diagnosis? So there's certainly something empowering around hearing from people within the ADHD community, and hearing from people from groups that maybe aren't always represented in the research, often comorbidities such as learning differences. We've talked about kind of the trans and non-binary community, or kind of even those who have co-occurring autism, which we know occurs at least 50 to 80% of the time, in the research aren't always represented there. So I think embracing ADHD and its co-occurring needs, neurodivergence as a whole, is a great place to start and kind of tailor it from there, really.
Definitely. And for any clinicians who are interested in, is there any research on this? As much as we're seeing there needs to be more, there is a great study done by Durrani and colleagues. Professor Sandra Coy was one of them in 2020, where this is exactly what they wanted to look at. They said, okay, we think this happens. We think this happens to females, that hormonal changes are going to affect ADHD. Let's study it. And they do have a good study, which is out there, which is open access, so people can go and take a look at it. They look particularly at premenstrual dysphoric disorder. They looked at postpartum depression, and they looked at perimenopause. And what they did find is that in these women, the prevalence rates are higher. Women who suffer from ADHD are more likely to suffer from these hormonal conditions that can happen, hormonal changes, etc. So for anyone who's interested in it, there's a great paper for people who want to know more.
Brilliant. Thank you. That sounds like a perfect place to summarize and round things up.
Yeah, I'd just like to say thank you to everyone who's listened in. I know that we've all three of us have learned an awful lot while we've been doing our research around this topic, and just ask you to listen in. And obviously you've mentioned some other comorbidities, so there's going to be a lot of other discussions, not just between us but some of our other colleagues, and yeah, hope you can join us. Thank you.